There you go. So we are recording. So as we get things going here, just kind of reviewing our agenda for the day. We are going to spend some time kind of pursuing really goal number 3 primarily, or goal number 2, I suppose. We're very excited to have a couple of model developers and people who are running models in New York State joining us today. That's going to be the bulk of our agenda today. So we'll get to introductions in a moment there. I'm not sure if Annie is on the line yet, but I know Vera Fuhrer from Northwell LIJ is on the line. So welcome, Vera, and thanks again for joining us. So today our objectives are to really gather insights from these national best practice models on behavioral health urgent care or behavioral health emergency department. And ultimately, we want to see those ideas and best practices make their way into Connecticut's plan and recommendations for a behavioral health urgent care model. And then ultimately, all the recommendations from this group, as a reminder, go up to the Children's Behavioral Health Plan Implementation Advisory Board, as well as the 12 state agency commissioners that are named as part of that behavioral health plan. So with that, I will turn it over to Tim Marshall for any other comments he wants to make, and then we will get things started.
So good morning, everybody. Thanks, Jeff, and thanks everybody for joining us. We're just approaching about 20 folks here at 19. So again, appreciate, I guess, especially because we had 2 weeks of back-to-back meetings with this group. So appreciate your commitment to coming together to help us to continue to think this through. We will hear today from one model or a couple of models, and we'd like to not that this part of the work will have been done, but we want to also begin to pivot looking towards our next meeting to start to think about the crisis stabilization level of care also. So we will continue to work on this and hear from today's presentation, but we'll start to look to work on both of them concurrently. So thank you, Jeff, and I'll turn it back to you.
Okay, great. Unless Annie is on the phone, and if Annie, are you on the phone? Okay, it doesn't look like she has joined us yet. So I'll probably, Vera, if you're okay with it, I'll just turn it over to you to go first. You were second on the agenda, but we'll turn it over to you first. And in the meantime, I'll just send an email over to Annie and see if she's going to be able to join us. So please feel free to introduce yourself, and then we'll kind of get things going. Thanks again.
Yeah, thank you. And thanks for inviting me. I'm happy to, share with you guys what we have done over at Cohen's Children's and how that's been working for us, and then how the pandemic sort of shifted things here as well, which I'm sure is the case for you guys also. So we call this the right care at the right time, and we're going to talk about our behavioral health urgent care model. If you're not familiar with Northwell, we're not so far from you guys. This is Long Island. We at the Children's Hospital are right here in the middle, but really Northwell extends to Staten Island, to Westchester, to way out to Peconic Bay in the Hamptons. So it's really a big health system with 23 hospitals, and these programs that I'm going to talk about today are at the Children's Hospital. Of emergency psychiatry care occurs definitely within Northwell, but also I think the volume of our service is probably, along with Annie's, the busiest, at least in our region. Here we go. So, I mean, this I'm going to jump through because you guys know what the problem is. Child psychiatry access is a problem. Now with the pandemic, it's become even a bigger issue. Some things have improved, and there's so many interesting models, your state with the mobile crisis program and many others with other different ways of trying to impact on this. But really accessing a doctor, a child and adolescent psychiatrist in particular, remains a challenge. And because that is a challenge, even if you are in care, it's a challenge to immediately access your doctor. A lot of the times, the only place to access is in the ED. So care gets pushed there. And there's, we know there's not enough child psychiatrists, but what are the ways that we can sort of maximize the reach of the ones that we have? Because all roads lead to the emergency room. Everybody, families, child protective services, schools, community organizations, everybody sends to the ER. And sometimes the kids really need to be there, and sometimes they really do not. And it's certainly not the best place to engage families. You know, this number, this is so outdated. It's 2015. This is the last published data on this that I found from 2019, but this trend continues to increase. And we know in the pandemic, we've seen a further increase in these pediatric ER mental health presentations across the country. And then, like I said, the ER not definitely the always the best place to engage people. There's so many other things going on. And then what resources are available, how much we can coordinate care with outside agencies, the lack of continuity, sometimes the way that we manage patients in the name of safety can be quite stigmatizing, and really just shifts resources in already overwhelmed emergency systems and is a very high cost. So we do need other models. And in 2017 at Cohen's Children's, we had started our behavioral health urgent care, which basically has been a shift of, you know, why these kids don't necessarily need to go through the entire ER process. They really just need to see a child psychiatrist the same way as they do in the ED when they walk in. So we started with whatever existing space we could find in the hospital, which was shared medical space with other ambulatory services. Had a child psychiatrist, a mental health counselor start working up there, and started behavioral health urgent care, because this program in an ambulatory setting that is a more 5 days a week, you know, school hours, business hours operations, which does give it an opportunity to better collaborate with community resources and schools, and in an ambulatory setting without the ER, really engage patients and move these patients out of the ER so that the really acute kids can get more resources down there. So that was the initial model. And then that most kids that we see in the ER don't need the inpatient unit, they need outpatient care. And sometimes they need that immediately. They cannot wait 2 weeks, 4 weeks, 3 weeks, a month, 6 months, however long it takes, they need it now. So we then started utilizing this service as sort of our bridging clinic or crisis clinic. And in addition to seeing kids that are walking in for assessments, we also started seeing them for follow-up care temporarily while we were coordinating ongoing care for them and supporting the families in making sure that they are connecting with the care that they need, which is also very difficult to do from the ER, but was much, you know, more feasible to do from this setting. So there's other existing models, and these are few of them, not even all of them, but there's different ways that people try to meet these needs of having same-day access to a counselor or a specialty child psychiatry assessment, a same-day access to a doctor that can prescribe or another practitioner that can prescribe, engagement, care coordination, aftercare, and then prescribing. And then some of the models meet some of these needs, and some of them, you know, meet less than others. But really, what behavioral health urgent care was trying to do is really provide all of these things, because these were the things identified as these families in crisis are needing. So the urgent care at Cohen's is up on the lobby level, which is very nice. It actually looks different now. It's even prettier, but it's a very welcoming space in the Children's Hospital, and our urgent care is located in one of these back offices. We're open, like I said, Monday through Friday, 8:30 to 4:30, which helps us connect with outpatient providers in schools and pediatricians. And then the kids we serve are 5 to 17, all insurance is accepted. And then really referral, I mean, it's a walk-in service, so really anybody can come. But who we want to see is kids in subacute crisis, kids that do not need medical care. So there's not a recent suicide attempt or agitation, not a need for a pediatrician or lab work or medicating, because we cannot do that. But a child psychiatric assessment we can do. Our funding at this point is fee for service. We started out with a New York district grant and had some deficit funding the first few years. It wasn't very large amount, and we're hoping with our volume up, we're hoping that we'll be, we're breaking even without it. Our staffing in this model is, centered around the child and adolescent psychiatrist who supervises every single case and sees every case, at least briefly, but they do have folks working with them and extending them. We have psychiatry fellows and residents. We have licensed mental health counselors. We have a medical scribe who scribes for the attending and helps them see, patients on their own, and as well as supervising the other folks. We have a patient engagement specialist who's really a combination of, we have no nurses, so there are flow person, they're the throughput person, they communicate with the other members of the team, they do vitals, but then there also are security. They're actually mental health techs, or I'm not sure what they're called in Connecticut, but they're mental health workers that get additional training in verbal and physical de-escalation, and they actually really truly wonderful and work with the patients from the moment that they enter the space. And then we have a financial registrar who does, registration, billing, copay collection, answering phones, help support referrals with phone calls, faxing, things of that nature. So far we have seen since May of 2017, when we opened, about 6,600 families. 50% of our referrals do come from schools. That decreased during the pandemic, understandably, since the kids were not at schools, they were at home. And the home referrals have increased during the pandemic. We'll see how that, will change again come September. And then pediatrics is a growing number of referrals, and we have been working hard with our Northwell pediatricians and other pediatricians to be aware of behavioral health urgent care and to refer kids there instead of sending them to the emergency department, unless, again, the emergency department is what's warranted. Most common diagnoses that we see are kids with adjustment disorder, depression, and anxiety, and about 50% of our referrals have some sort of suicide or self-injurious chief complaint, and that's what we're assessing. That's why kids are referred from schools. And then our major results since opening is that the service, when it opened, did decrease ER volume as it was intended to do for this trip. It also decreased the number or percent of inpatient admissions, and then it consequently decreased the level of boarding that we had to do in the emergency department. Kids that come to the urgent care, 96% get discharged, about 4% end up going down to the ER, and then most of those go over to an inpatient unit. Sometimes they go down to the ER because there is some sort of medical concern that we do need checked out, and we refer them down there because of that. But most kids are able to go home. About 78% of the kids that we see receive some sort of new referral for outpatient care. So that is why they're coming, because again, there's no access, and they're looking for access, looking for help in connecting. And then, we do have high satisfaction rate with the service. Its families appreciate the access. They appreciate that if they do need care or they need to be started on medication, they can do that in this setting, and that, a lot of the times, importantly, that they can avoid the emergency department. This graph, I actually didn't update with the 2020-2021 data, and I have more, but pretty much the trend has been similar. In 2020, as expected, we dipped in volume compared to 2019 when we had about 2,000 visits. In 2020, we went down to 1,600 for urgent care. But we already year to date this year, we're about 1,400. So I am pretty sure that by the end of the year, we're gonna be well above what we were before. And this graph, you can see how this impacted the ER. So prior to 2017, for years, we were in this trend that's published in the literature of continuously increasing presentations, hitting about 3,200 in 2016. And then when we opened urgent care in 2017, the trend of increase continued and intensified until the pandemic. But that blue column is how we shifted that care to the urgent care from the ER, and the ER presentations actually decreased. And as you can see on the 2021 year-to-date bar, at this point, and even last year during the pandemic, at this point, even though this service is 40 hours a week, it sees almost as many kids as our 24/7 ER.
Vera?
Yes.
I don't know if you can see the comment box, but we already have a number of questions. Do you mind if we address a couple
go
of them
ahead,
right now? All right, first of all, an easy one. Are you willing to share your slides with this group afterwards?
Yeah, of course.
Okay, great. I figured that was the case, but we'll make those available, everyone. Going back a couple of slides, there was a question about whether clients are not accepted at the urgent care if they're deemed to be too agitated. Can you talk a little bit more about that?
Yeah, so you know, it's a clinic setting, and it was initially and continues to be co-located with a medical service. So we're utilizing the medical urgent care service, which used to be a formal urgent care for the Children's Hospital. At this point, they're using it as ER overflow, but they do see patients, other patients up there, and it's a clinic setting. It's an office. There's no nurse, there's no medications. So if kids are not cooperative with the visit and are not in good control, it's difficult to see them there. But in all honesty, we don't really have an issue with this because it's a walk-in service, an ambulatory clinic where people need to walk into. So it sort of self-selects. We never really had kids that we had to turn away because they were too agitated when they walked in. But the ambulances bringing agitated patients, you know, they're all received at the ER.
Okay. And another question here, can you describe how these patients were managed by the hospital prior to creating this unit?
They were all in the ER.
Okay, just kind of
they
getting
were all seen in the
care.
ER. We have child psychiatrists in the ER, and you know, I mean, that's a whole other presentation. But from 2012, when the volume increased, we like changed our entire ER structure and built this big multidisciplinary team. And we have a specific space in the ER, so we have always had a lot of visits. But most of the kids did not need to be in the hospital, which is why this service was then developed to give them an alternative.
Okay, another question having to do with a clinical exclusionary criteria, essentially. Was there also a comment about recent suicide attempts being something that's not seen at the urgent care?
Yeah, so really only if it requires medical, you know, workup. So if somebody took an overdose that morning or even the day before, and you know, no medical provider has seen them yet. Again, we don't have nurse, we don't have labs. You know, it's like essentially an outpatient child clinic in the hospital. So, child psych clinic. So, so those kids, again, if they need a medical assessment, if it was, you know, a week ago and it wasn't significant, or 3 weeks ago and it was, you know, then if they don't need a medical workup, then it's fine. And we often do discover that while we're seeing kids and during the interview, they tell us something, and you know, we make a clinical judgment call about like, does this still require a medical assessment and labs, or, you know, at this point, they're okay and we can just assess them.
Okay. Let's see, there's a few more here, but let's save those for the end. And if you want to go ahead and keep going with your slides. Thanks for answering those.
Yeah, sure. Yeah, feel free to interrupt me again. So this is the change in the ER volume. So most months a decrease ever since we opened, and then some months, we had these spikes in ER volume, but overall, big decrease in the ER volume since we opened urgent care. And of course, with COVID-19, we had that initial period in the lockdown that the volume significantly dropped. And then by the summer, we were higher. And then in the fall, we started out lower, and then since then we've been steadily increasing, and our volume is higher than it has ever been in both urgent care and the ER. But at this point, it's hard to say what's the pandemic and what's the impact of urgent care. The impact on inpatient admissions when we opened was a pretty significant increase from a previous average in the 20s to a 16% admission rate that since then creeped back up to about 19 since COVID hit, and we are seeing higher acuity kids in the ER. But in general, having urgent care and having that as an alternative to an inpatient admission in terms of starting immediate care and having the ability to bring back a high-risk patient the next day to check in, a lot of the times the families also prefer and accept that, and that has allowed us to be able to discharge kids that, again, might not need inpatient care, but they do need immediate care and a high level of check-in. The boarding, this shows the boarding decrease when we started the transitional care arm, which is this bridging service where we started bringing kids back in. We started that a year after opening, and then we did see a shift in decreasing the number of boarded kids in the ED. This is not updated either because, again, the pandemic has had unexpected changes on our boarding patterns, which I'm sure it did for you guys, but it had a lot more to do with bed availability and switching and quarantining units than it had to do really with patient acuity or anything else. So again, it's one of those examples when I think it's more indicative of COVID. And then one significant decrease, which again, we had a change during the pandemic quarters, what we're back down to a fairly low number, is this decrease in repeat ER visits. So because now we were scheduling high risk kids to come back in a scheduled manner to urgent care, and having that as an alternative has impacted on the ER repeat visits and repeat presentations for kids. And then impact on the ability to link kids to ongoing care from urgent care versus the ER. So 78% referrals to new care, 18% go back to their existing care. The percent of that is much higher in the ER. Like we do see kids in the ER now that 50% of them are in care or 60% of them are in care and they do not need new referrals, but people are accessing urgent care when they're looking for new referrals. And then we have developed community partnerships with CBOs and schools and pediatricians, and really trying to work with the network of these families and patients to be able to refer and get them into care. We do refer to our own Northwell ambulatory practices as well as community organizations and private practices, really anything we can access. A pilot that we've done with Zucker and we continue to do is an open access pilot, which in our own clinic, they just give us specific appointments that we're able to give out at urgent care visit in real time. And 92% of those kids do connect and link and stay in care at that clinic. So having that seamless transition and being able to coordinate so closely is definitely helping linkage. It's much more difficult when we have to wait for weeks for, to get an appointment for them. So really the lessons learned, and then I think it's, we can go back to the questions, is that the physical proximity to our emergency department being one floor up has really helped us with sort of having this no wrong door policy. So if somebody comes to urgent care and we do think they're too acute, we can send them down to the ER. If they need medical care, we can send them down to the ER. And similarly, if they come into the emergency department and urgent care is open, we have a workflow of triaging kids out after a medical clearance or medical screening exam, which allows families to access the care that they need. And then we also share staff. So it's all one team covering. So when urgent care is busy, we send staff up from the ER and vice versa. So the team works together, and that really helps in terms of financially being able to sustain the service. They're co-located with medical services, which actually helps in acceptability and family engagement. Being in the lobby, being just like another service at the Children's Hospital does make a big difference, as opposed to the ER where we put people away in the back room in a locked space. Here they're up, up in the same space as everybody else. And then we have been able to economize some of the administrative staff that works with the medical services, which also, again, just helps financially. And then collaborating with community services of all kinds and schools and pediatricians are really important, and is actually the start of our new program, which I'll talk about in a sec, but really has been important in terms of being able to get these kids into ongoing care, which is ultimately what they need. And the medical scribe, I think, has been a great investment. It's very well accepted by families. It does allow us to just pay attention to them with somebody else taking notes, and it increases productivity and decreases burnout and really increases physician satisfaction and engagement. We all love our scribes. And then our service is aligned with school hours, which again supports care coordinations. We do know that the hours right now are a little bit of a barrier for full impact, because families would like to come in the evening and on the weekends, and that care still overflows to the ER. But it's a balance and space availability and many other things that are being considered, but we may be extending the hours at some point. And then having flexible staff roles and having folks like the patient engagement specialist and financial registrar that really have multiple roles, again, just helps in terms of sustainability of the program. And I saw that there was a question about funding. So initially, like I said, we had some grant funding, but right now we're just fee for service and, breaking even just about. So expanding hours, expanding more of the transitional care arm are two ways that we're growing, and then really expanding the model to community-based service that works with schools and actually is contracted and partnership with schools is where we're going now. And we have built this network of school partnerships. At this point, we have 17 Nassau County school districts that are contracted with us and actually are funding this program or funding most of it. And these programs consist of behavioral health centers that are very similar to our urgent care, but then they're also doing a lot of prevention work in the schools, and we do community education, staff training. We can go into the school and do formal consults, and we're really working together with them to get kids linked to care and get them the care that they need, and partner closely in supporting these families, and whenever possible, getting the pediatricians involved as well. And this we started last January, and then the pandemic happened, but it's one of those things that the pandemic actually had, I think, a very positive impact on this program, and the acceptability by schools, and the quick trust that was built by shared difficulty. And we really, it's really a very rich collaboration and very promising to be able to bring this model to the community. And we have seen with the districts that we have been working with since last January, which was initially 5 districts, we have seen an average of a 60% decrease in those kids from those districts presenting at Children's Hospital. So instead of the Children's Hospital, they're now accessing this service in their community. And that has been really, I think that has a lot of promise, and that is where our next steps are, is growing these programs. And I'm going to stop there. Go back to the question.
All right. Wow. That was that was very informative. Thank you so much, Vera. I know we have a number of questions in the chat box. If you want to drop your questions there, that's fine. I see Annie has joined us. Hi, Annie. Thank you. I just give it, how about we just take a few questions and then turn it over to Annie to talk about her model as well. Just pick a few off of the list from the chat box. A question for you, Vera, about what does your inpatient bed capacity look like in the surrounding area around your hospital? And is that an issue, or are beds generally available when that's necessary coming out of the urgent care?
Yeah, I have to say we are very lucky, I think, compared to other places, because within our own network, we have quite a bit of beds, and usually, we do have that. Sometimes we don't have beds available and kids have to wait, but for the most part, we have beds available within 24 hours. We have an inpatient unit on campus that's an adolescent unit with 22 beds, and then we have access to 4 other units in other Northwell hospitals, 1 pre-adolescent and 3 adolescent units that we have fairly direct access to.
Just for a sense of scale for our benefit. From a population standpoint in your hospital's catchment area, what kind of total population do you have? Just so that we can kind of put that bed capacity in the context of Connecticut. Do you have any idea, or just
somebody's gonna Google it? I don't know.
Fair enough.
I should know, but I don't. A lot.
Okay. So
the reason why these beds are, we do have access, and then like you guys saw, our admission rate is really, really low. So we only admit 18% of the kids, not, or some years down to 16% of the kids. So that's really significant and much different, I think, from other places. So I would say that is also part of the reason why we don't have a humongous boarding problem. Again, during the pandemic, we did, because our units were on quarantine. The health system was using some of the adolescent beds for COVID adult patients and COVID units, psych units that we had to run. So there was a lot of load balancing. So that became a difficulty. But I think, compared to other places in New York, we have more direct access to beds, I think. Annie will tell you, they also have access, but, it's difficult.
Right. Okay. I don't think we're ever going to get to all the questions, but I
can try to answer some of them in the chat while Annie's talking.
Okay, that would be great. Thank you for that. So why don't we just do that? Why don't we shift over to Annie? And Vera, thank you again for a great presentation, and I'll turn it over to Annie.
Bear with me. I'm just trying to make sure there we go. All right. So good morning, everyone. Thank you for allowing me to jump on after just finishing walk-arounds with my team. I'm Dr. Annie Lee. I am the director here of the Bellevue Children's Comprehensive Psychiatric Emergency Program. We're part of the New York City Health and Hospital System, and our base is at the Bellevue Hospital Center. All of our faculty members here, the attending psychiatrists are all NYU affiliated, so we do have academic relationships with NYU Langone. So just a brief overview. The program itself has been around now, I would say, for I think 10 years. I am, believe it or not, the 3rd director to be serving in this role. This was previously served by Dr. Ruth Gerson. It is the only emergency psychiatric program in the state of New York that functions in this Cpap designation, which is the Comprehensive Psychiatric Emergency Program. And for us to be able to earn this specific designation, we are required to have a certain arms of treatment under this umbrella. So there are certainly comprehensive psychiatric emergency programs for adults throughout New York State. We are the only one that specifically serves children here in the New York State area. For us, one of the main criteria to be able to earn this designation is that we really need to have a child analysis psychiatrist always present 24/7. In addition to that, we are a multidisciplinary team model. We have nurses, social work, medical, obviously administrative staff, and we are a major training site for not just our child adolescent psychiatry fellows, but also for our psychiatry general residents, our psychology interns, our medical students, and visiting medical students as well. We are located on the ground floor. We are actually separate physically from the psychiatric emergency room. We're kind of like a 2-minute walk away from them. So we are a separate entity, you know, for kids. So believe it or not, under the Cpap umbrella, as I mentioned, there are a couple of arms that, you know, the program exists. There's the emergency evaluation area, where we, you know, do our evaluation as though they're walking into, let's say, a clinic. The difference is that we're a completely secured physical space. So anyone who comes in, they stay there. We have a designated staff to observe them and watch them. And then we do our evaluation. And usually when we do our evaluation, it always is in tandem with, let's say, a social worker, a trainee, or one of the attending psychiatrists. We'll talk to the mom, we'll talk to the parents, we'll talk to the kids, we'll obtain the appropriate collateral information, and then we make a determination as to what is the appropriate disposition for this patient. A lot of the times we treat and release them, we call it TNR. And if they have existing outpatient providers, we make sure that we coordinate with the existing outpatient providers to make sure that they have a timely follow-up, usually within 5 to 7 business days after they're discharged. Sometimes that doesn't happen. There are no outpatient providers. And they need outpatient follow-up, but we still feel that they're appropriate for discharge, in which case we have if you look at our outpatient acute care arm, we have a crisis clinic. And in that crisis clinic, we are allowed to follow up with patients up to 3 sequential visits, usually spaced out 1 to 2 weeks apart. So we're able to kind of bridge them for 4 to 6 weeks while we're able to work on securing a more longitudinal, long-term mental health treatment team for the patient in their respective community. Because we are New York City, we actually get patients from all 5 boroughs. Even though we're physically located in Manhattan, we get patients from Staten Island, Brooklyn, Queens, New York City, Manhattan itself, and the Bronx. And so a lot of times we really try to strategically refer patients back to their respective borough. During COVID, a lot of telepsychiatries happened, so it created a lot of fluidity for us to refer. However, I think with a lot of transitions, you know, uncertainties related to telepsychiatry reimbursement, we are making sure that we refer them back to their respective catchment area. When a patient is not eligible, let's just say, for treat and release, and they need a higher level of care, obviously 2 potential options exist. If we feel strongly that, you know, they definitely need inpatient psychiatric hospitalization, Bellevue itself has 3 psychiatry inpatient units, 2 dedicated for adolescents, 1 for children 12 and under. So we have our own capacity to provide inpatient psychiatric services for patients that pass through the child Cpap and are in need of inpatient admission. What we also have that's very unique, and that's not something that is always available, but it also makes it a requirement for us to be a Cpap designation, is our pediatric extended observation unit, which is called a POU. We actually have 6 beds. And patients can be admitted on what we call a pediatric or extended observation unit status, which is in New York State, the 940. And a patient can be held kind of like similar to like the Baker Act and other states for up to 72 hours. And that is on the discretion of a psychiatrist. It's kind of like our emergency hold. And we're able to observe and stabilize patients for up to 72 hours to make a determination whether they can be discharged and returned back home with services, or they actually need to be converted to our admission status and for them to subsequently go upstairs to an inpatient bed. So in that unit itself, we have nurses, we have behavioral techs to be able to supervise and make sure that all appropriate care are provided for the patients. In addition, so that's the POU arm. And then in the outpatient arm, I talked about the crisis clinic, which allows for patients to be followed up to 3 visits here. You know, if we start medications on them, then we can bridge them to follow up. We usually primarily don't engage in like really intense, deep, like therapy with patients on crisis clinic visit. It tends to be more like a safety assessment, kind of a functional assessment to see if the child and the family are doing well. Are there any crises that we need to be accounted for? And, you know, checking in and, you know, providing them with specific instructions like, hey, you know, we're making a referral for you to this specific program. And let's make sure that you do everything that you can to, you know, attend your intake appointment at, let's say, this specific community health center so that you'll be plugged in and transition to long-term care. We also have home-based crisis intervention, abbreviated as HBCI. And what HBCI does is allows for, you know, a caseworker to kind of go into the home, offer some, you know, parental intervention, guidance, some mild behavioral, you know, modification, you know, services for the patients and families. This usually is like also like a average 4 to 6 week intervention in home. They go into the family's home once a week, identify specific objectives that they want to achieve, and devote those 4 to 6 weeks to making those objectives kind of become more sustained in the home. We used to also have mobile crisis. However, I think one of the recent changes in the past 6 months, namely, I think ever since 2021 commenced, is that New York City outsourced a lot of the mobile crisis services from hospital-based to more community organization-based. So we no longer actually have mobile crisis as part of the umbrella for the Bellevue Child Cpap. And so, as I said, we're open 24/7. Patients usually come through to the psychiatric emergency room. They get triaged, you know, and then they get walked over, and we do the most complete psychiatric assessment, and we make those determinations. We get walk-ins. You know, we get a lot of EMS calls as well. We get school referrals. We're also physically next door to the New York State Children's Center, operated by our Child Protective Service Agency. So patients that are temporarily removed from youths that are temporarily removed from the home for a myriad of reasons also gets placed there indefinitely. And if there is an issue, they get brought over here from there for us to evaluate them psychiatrically. And we do also sometimes get transfers from other hospitals. Especially with certain NYU patients that come through their ER, they get transferred here for higher level psychiatric assessments. So we are a fairly big team. You know, we're actually kind of actively recruiting for more psychiatrists, but we have, you know, 4 attendings, and we also have nocturnalists that help us with our overnight coverages. We're also really lucky that we have psychology attendings who help in terms of being able to offer a set of milieu and structure when we have patients in our extended observation suite. The picture down here is a picture of our extended observation suite. So this is our common area lounge, and this is one of our staff building exercises that we did when we had no patients in the POU. But you can see the common lounge, and then everything on the left are doors to the respective patient rooms that we have. We also have a robust team of social workers that helps us in terms of disposition and coordination of care. We have nurses and also an administrative team helping us with registration and a lot of regulatory things. So in terms of regulation, I was seeing some of that floating out in the chat. We are under, I think, Department of Health guidance. We're also under the Office of Mental Health of New York State guidance as well. So everything has to be outfitted based on New York State Office of Mental Health regulations. So we get site visits from the Joint Commission and the Office of Mental Health New York State on a periodic basis to make sure that we're in compliance. So obviously, this is a program that requires a lot of resources. And, in the ideal world, we would be able to have insurance, reimburse us for everything and cover it. Some of our staff funding is provided by a New York State grant. And then the other components of it is that, when we have patients that come through and get admitted to extended observation suite, it actually goes to insurance and it's considered as the beginning of an inpatient psychiatric hospitalization. And then, the patients that are, seen and evaluated, they actually end up, going through for reimbursement codes as a actual, initial psychiatric evaluation for us. So, one of the things that we've been doing is that we recognize that not every hospital can operationalize and, provide this level of comprehensive care, especially within the New York City Health and Hospital, because it is so resource rich. In recent years, we have noticed that within the health and hospital arm, the need for child psychiatry evaluations and consultation has been really robust. So actually, one of the programs that we're building right now within the umbrella arm of the Cpap is to create a consultation telepsychiatry services to our campus affiliates across H&H to see if we can help support them. And when they have patients that come through to their emergency rooms, we're in the process of building a telepsychiatry service where we can serve as consultants for them to be able to offer some guidance and in terms of treatment stabilization and disposition coordination. So that's like the next big project that's for us here at the Child Cpap. So I don't have that many slides. I try to keep, the orientation and overview of a program fairly kind of concise. So I want to make sure that I open up to others for questions because sometimes that's information, exchange that must be more specific to everyone's needs.
Great, thank you, Dr. Lee. I will just open it up to questions. There are a couple of things in the chat box, but I'll just open it up to questions if you want to take yourself off mute or raise your hand. Let's just take it for there, either for Dr. Lee or for Dr. Fuhrer.
I put a question in if you don't mind,
Sure.
Jeff. I'm a child and adolescent psychiatrist at Yale New Haven. It's impressive to have, when I looked at the staffing yesterday in the document that you sent, that's impressive faculty staffing. And I'm sure there's very few other hospitals in the country that have 24/7 child and adolescent attending psychiatrists as nocturnists in order to be there overnight. And I was surprised actually, given the number of beds, just 6 beds for the overnight. So any idea what percent? So it's grant funded and state supports it, but what percentage is covered by insurance billing versus continued support from the state or from Bellevue?
Yeah, no, I don't have the direct thing. I don't have the direct breakdown. What I can say is that, I think I don't have the direct percentage, but I can tell you the sources of funding that we get. I mean, obviously grant funding is one of them. We do try to recover as much reimbursements as we can. We know that that's a finite. I think one thing that we are, I think, really fortunate to have is the affiliation with NYU Langone, who also helps supports, part of the service funding for this program. So I think our funding sources come from those 3 specific avenues.
Great. Any other questions?
Well, Jeff, it'd be good to hear, and my apologies if it's already in the chat room, sort of the same breakdown, with respect to the Northwell operation, if that's possible, Dr. Foyer.
Yeah, so we have two services, and the ER service, not quite 24/7 like Annie's, but we do have 18 hours of child psychiatry attendings a day, and then 6 hours of our graveyard from 1:30 a.m. to 7:30 a.m., which we don't have an extended observation unit, and we have very little volume during those hours. Those hours are covered by our Northwell Emergency Telepsychiatry program, who cover remotely all the hospitals in the health system when they don't have staffing, and they cover us for those 6. So I do have a total of 4.5 FTEs of child psychiatry time in the ER, 1.2 in the urgent care. And in addition to that, we have one nurse practitioner in the ER. We have some moonlighter time with trainee moonlighters. And then we have 2.5 FTEs of social workers, psychiatric social workers that are covering a period of 8:30 a.m. To 12 every day. And then in the urgent care, we have 2 licensed mental health counselors. And so that's our clinical staff. And then nursing, patient engagement specialists and techs, that's the ER's staffing. So they staff those positions 24/7. Some of those nurses are always, our behavioral health nurses, and some of the shifts are filled with the pediatric nurses. Same with the techs. Some of them are general ER techs. And on the busiest shift, the 3 to 11 shift, we have a dedicated patient engagement specialist in the ER. And our reimbursement, like I did put in we're not OMH, we're DOH, we're Children's Hospital Services in both the ER and in urgent care. And in urgent care, like I said, we break even on the salaries. I mean, the indirect savings from urgent care, probably balance out the indirect costs, because not having kids in the ER, not having as many one-to-ones down there, and not needing as much staffing in the ER, which is very expensive, probably saves more money than them giving us space and, all of those.
Great. So we have about 5 minutes left. I just very quickly want to say we will post minutes from today's meeting. We will also post slides and materials on our website, but we also are going to include the questions, comments, and responses in the chat box at the end of our minutes. So just wanted to let the group know about that. One more question. I'm going to just looking at Amy Evison's question. Can you talk? You talked a little bit about the just general crisis stabilization and medication management services you offer. Can you talk a little bit more about services or treatment that's being offered while the children are in the milieu of either of these settings?
Yeah, so I could say that in the child Cpap, and I can cover that too about the COVID positives too, because that's certainly something that we had to contend with since March of 2020, let's just put it that way. I think going back, we're really fortunate to have psychology attendings because they help us with the bulk of some of the milieu. A huge part, I would say that, we're a program that is very, emphasis on trauma-informed care. We do see a lot of patients who come in with, trauma, complex trauma. And so a lot of our milieu is really focusing on trauma-informed care, really kind of identifying things that can be as, what are some areas of the environment that can be helpful in terms of, reducing stress, how to identify strengths of the family and the support system networks, and identifying resources to kind of create a more robust support network for these youth. So a lot of our milieu is focused on that. One of the things that we have is what we call an autism spectrum pathway. So it's kids with special needs, autism, intellectual disorder. We actually have a very specific pathway with visual cues and everything to be able to engage with them, to come up with a concrete routine and structure and expectations for the day. Very behavioral models based, rewards, first do this and then do that, and really kind of, holding patients and families more in a very accountable and empowering way to kind of take back agency of some of the things that contributed to the crisis. So that's a lot of the work that we do while we're down here in the POU. In terms of COVID, so because we are a 6-bedded extended observation suite, I was just actually talking to one of our head nurses that we have a room on standby for isolation. At any point, if there is a patient that's positive, we put them in there. If we have more than one, we cohort them together, and they are to remain in isolation and quarantine for the duration of their time. We're lucky to be able to advocate with a hospital to be able to access and provide us some rationing of the rapid testing for COVID, so that it allows us to kind of move patients in a much more quicker way, so that we can quickly test them and kind of cohort them appropriately. So that's one thing that we've been able to do. We also have dedicated beds upstairs on our inpatient unit, just similar to Vera, for COVID positive patients. So, and in one of the sections of the unit, there are these fire doors that kind of close and open up. So if we need to, create a little mini unit of COVID positive patients, we are on standby, ready to be able to do that.
That's what our unit does too. That's exactly what they have.
Yeah.
Okay, so we are 2 minutes to the end of the hour. That was an extremely efficient 60 minutes. I want to thank both of our presenters. That was very, very informative for our group. I'm knowing this group a little bit as I do over the last couple of months in particular. I imagine you all have a lot of additional questions, maybe even some thoughts, reactions, responses about implications for our Connecticut's model. So I'm going to follow up with this with an email to all of you while it's fresh in your mind. If you have thoughts about, what do you like about these two models? What are some things that are great fits for Connecticut? What are some things that you think may not be great fits for Connecticut? I'm going to be sending that out this morning. So if you have some thoughts, please, by all means, send them along to me. We want to collect that information from all of you. So thank you again very much to our presenters and to this group for making it here. And we are at the hour. So have a great rest of the week, and we will talk to you next time.
Great. Thank you. Bye-bye.
Yeah,
Bye, everybody.
thank you.
Thanks all. Bye.
See ya.